Hi everybody, and welcome to our module on Parkinson's disease. Parkinson's disease is a movement disorder that is caused by loss of dopamine-containing neurons in the substantia nigra, which is part of the basal ganglia and it's found in the midbrain. These neurons provide excitatory input to the motor cortex, meaning they encourage motor activity to occur. So when these neurons lose their function, the patient develops difficulty with movement, and for that reason Parkinson's is a hypokinetic movement disorder. The major risk factor for Parkinson's disease is older age. You are also at increased risk if you have a family history of Parkinson's disease. And then finally, for reasons that are poorly understood, smoking lowers the risk of Parkinson's disease. It's a protective factor. There are a small number of conditions in which the risk is lower among smokers, and Parkinson's is one of them. The diagnosis of Parkinson's disease is clinical. It's made based on the patient's findings. There are no imaging tests or blood tests. And you can make the diagnosis when the patient has the three classic features of Parkinson's disease. One is bradykinesia, one is tremor, and the other is rigidity. If you look at the bottom of the screen, bradykinesia is difficulty initiating movements. We'll talk more about this in a minute. The tremor of Parkinson's disease is often the initial feature that brings the patient to medical attention. It's a tremor that is present at rest, and it's described as a pill rolling tremor because the patient looks like he or she is rolling a pill in between their fingers. It improves with movement, and it gets worse if you distract the patient, and this is in contrast to some other types of tremor which get better when you distract the patient. And then cogwheel rigidity refers to resistance to passive movement. This is best appreciated in Parkinson's patients by examining their wrist. If you ask the patient to allow you to passively rotate the wrist, you will see that there is resistance to movement. And then in addition to these three features, you can make the diagnosis of Parkinson's disease if there's no other alternative diagnosis. And then the diagnosis is usually confirmed by the response to therapy. If you think a patient has Parkinson's, but the patient doesn't respond to drugs for Parkinson's, then you have to consider another diagnosis. Let's talk in a little bit more detail about bradykinesia. Bradykinesia is a generalized slowing of movement, and it occurs in about 80% of Parkinson's patients. Because their movements are so slow, they can have difficulty with fine motor tasks, things like buttoning their clothes or tying their shoes. They often drag their legs when they walk and walk with short shuffling steps because it's hard to take a large forceful step forward. And in general, bradykinesia leads to feelings of unsteadiness on your feet, and Parkinson's patients are especially vulnerable to falls. Some other features of Parkinson's are shown in this slide. A masked facial expression is a classic finding. This refers to a lack of movement in facial expression. This man on the screen has the masked facial expression, and once you've seen this a few times, it's very easy to recognize in patients with Parkinson's disease. I mentioned that patients with Parkinson's take short shuffling steps, and so their gait is classically described as a shuffling gait. It's narrow-based with short steps, and they often freeze when they are trying to move. And then finally, late in the course of Parkinson's disease, after patients have had movement problems and tremor for a long time, they can develop dementia from Parkinson's. Many patients with Parkinson's disease develop a blood pressure problem called neurogenic orthostatic hypotension. This occurs because of loss of normal functioning of the autonomic nervous system. What happens to these patients is when they are lying down, when they are supine, they have hypertension, but when they stand up, they develop orthostatic hypotension and can even become dizzy and can have syncope. This occurs in up to 60% of Parkinson's patients in some studies, and it's more common in Parkinson's patients who are taking levodopa for treatment. And this can be a very difficult problem to treat. These patients have high blood pressure and may need antihypertensives, but if you treat them too aggressively for hypertension, their hypotension gets worse and they can have dizziness and syncope. Now we're going to talk about different treatments for Parkinson's disease, and this is the highest yield thing to know about Parkinson's. This is what they're most likely to ask you about on your board exams. So the goal of treating Parkinson's disease is to either increase dopamine activity in the central nervous system or to block acetylcholine activity. Dopamine and acetylcholine are in balance in the central nervous system, and when you lose dopamine effects, that leads to an excess of acetylcholine effects, and that's what contributes to some of the symptoms of Parkinson's disease. So the two ways to fix this are either to boost the dopamine effects or knock down the acetylcholine effects and try to restore balance between dopamine and acetylcholine. In terms of the drugs that target dopamine, there are basically four groups of these drugs. The first is the combination drug carbidopa-levodopa. Second group are the MAO type B inhibitors, and then we'll also talk about the COMT inhibitors and dopamine agonists. But the goal of all of these classes of drugs is to boost dopamine activity in the central nervous system. All of the drugs we're going to talk about in the next few slides for treatment of Parkinson's boost dopamine, and so any drug that modifies dopamine levels in the brain can potentially cause the 5 side effects shown on this slide. Nausea and vomiting is affected by dopamine levels in the brain. That's why the anti-dopamine drug metoclopramide can be used to treat nausea and vomiting. We already talked about how many Parkinson's patients develop orthostatic hypotension, especially those patients that take levodopa. And so this symptom is associated with Parkinson's and changing dopamine levels, and many dopamine drugs cause orthostatic hypotension. Excessive sleepiness is common with drugs that alter dopamine levels, and so is dyskinesia, which is involuntary movement. And then lastly, all antipsychotic drugs work by blocking dopamine, and that's because excessive dopamine effects lead to confusion and hallucination. And so in these drugs we're going to talk about soon that boost dopamine levels, you can see confusion and hallucination. So we'll talk about specific drugs, but this is sort of a general list of common side effects in any Parkinson drug that modifies dopamine levels in the brain. The first drug we'll talk about is carbidopa-levodopa, which is a combination pill with 2 components. One is carbidopa and one is levodopa. It's sold under the trade name Sinemet. So the idea here is that it would be great if we could just give dopamine to people and it would go into their brains if they had Parkinson's disease, but dopamine cannot cross the blood-brain barrier. So instead what we do is we give the drug levodopa, which is also called L-dopamine. It is able to cross the blood-brain barrier. And then once it gets into the central nervous system, there's an enzyme called dopa decarboxylase, which converts levodopa to dopamine, and this increases dopamine effects in the brain. The problem with giving levodopa by itself is there is a peripheral decarboxylase enzyme, which breaks down L-dopa into dopamine before it has gotten into the central nervous system. In other words, when it's in the peripheral vasculature and in tissues. This limits the benefit because it takes the levodopa away before it gets in the brain. It also increases peripheral dopamine levels, and that leads to cardiovascular side effects like tachycardia and hypertension. So for this reason, you give levodopa together with carbidopa. Carbidopa inhibits the peripheral decarboxylase. That allows levodopa to cross the blood-brain barrier and get into the central nervous system where it's converted to dopamine, and that increases dopamine effects. So therefore, you always give these 2 drugs together, carbidopa and levodopa. The major problem with this drug combination is what's known as the on-off phenomenon. So when you give this drug to patients, over time their brain begins to depend on the levodopa as its source of dopamine, and there ends up being a depletion of whatever natural dopamine production is left within the midbrain of the patient. When this happens, the patient becomes very dependent on levodopa, and levodopa has a short half-life of about 90 minutes. So this leads to the on-off phenomenon where they have an increased response to levodopa right after they take the drug, and sometimes the response is excessive, and then they lose their response between doses and their symptoms get worse. So the off symptoms are symptoms of Parkinson's that return when the drug wears off. These usually return 3 to 4 hours after each dose. Patients will start to have their gait freeze and will have other bradykinesia type symptoms that come back after every dose a few hours later. The on symptoms can occur shortly after the patient takes the drug. These are movement symptoms called dyskinesia. They are abnormal involuntary movements that are a response to the dopamine surge that comes from taking levodopa. So this is the on-off phenomenon, and this will happen after patients take carbidopa-levodopa for a long period of time. Besides the on-off phenomenon, Sinemet often causes 4 non-specific side effects. These are shown here: headache and nausea, sleepiness, and dizziness. And then in older patients, anytime you mess with the brain chemistry, you can potentially cause confusion and cognitive problems from dopamine excess. So some older patients on this drug develop confusion and hallucinations or delusions. Entacapone and tolcapone are COMT inhibitors. COMT stands for catechol-O-methyltransferase, and this is an enzyme in the body that breaks down levodopa and limits its effects. These drugs are only used in combination with levodopa, and the reason is because the idea of these 2 drugs is to boost levodopa effects and allow levodopa to last longer and therefore prevent the off periods in patients having the on-off phenomena. These drugs are levodopa boosters that you can give to people having problems from the off phenomena. Entacapone inhibits the peripheral COMT enzymes. Tolcapone inhibits both peripheral and central nervous system COMT enzymes. And the adverse effects of these drugs have to do with excessive dopamine stimulation in the central nervous system. Patients can develop movement problems like dyskinesia. They can also develop psychiatric problems like hallucinations from excess dopamine. In initial clinical trials, tolcapone was associated with hepatotoxicity, so LFTs have to be monitored in patients taking this drug. And then finally, both of these drugs can turn the urine orange because of a metabolite. This is a harmless side effect, but one that patients need to know about. Selegiline and rasagiline are MAO-B inhibitors. These drugs inhibit the enzyme monoamine oxidase type B, which is a central nervous system enzyme that breaks down dopamine. There is another MAO enzyme, MAO-A, which is inhibited by drugs that are used to treat depression. That's because MAO-A predominantly breaks down serotonin, so when you inhibit it, you boost serotonin levels, and that's helpful in depression. MAO-B breaks down dopamine more than serotonin, and therefore MAO-B inhibitors are used in the treatment of Parkinson's. These drugs boost central dopamine levels, and they can be used alone or added to carbidopa-levodopa. Their side effects are similar to the side effects of many other dopamine drugs. These include nausea and vomiting, hypotension, and excessive daytime sleepiness. And then because the MAO-B enzyme somewhat breaks down serotonin, in theory you can develop the serotonin syndrome if you take one of these drugs together with another serotonin drug. In actual practice, this is very rare and almost never occurs. Serotonin syndrome does occur when patients take MAO-A inhibitors together with other serotonin drugs, but it's very rare with the MAO-B inhibitors used in Parkinson's. So here's a summary slide to remember how all the Parkinson's dopamine drugs work. So you've got the blood here and the brain here, and this is the blood-brain barrier. Dopamine cannot cross the blood-brain barrier, so that's why you give levodopa. It will cross into the central nervous system where it will be converted into dopamine. By giving it together with carbidopa, you inhibit the peripheral conversion of levodopa to dopamine so that it's free to go into the central nervous system. And then when you use COMT inhibitors, they block the breakdown of levodopa peripherally or centrally into inactive forms. And when you give MAO-B inhibitors, they also block the breakdown of levodopa, this time in the central nervous system only. The last group of drugs that affects dopamine activity in the brain for Parkinson's are the dopamine agonists. Drugs in this class include pramipexole, ropinirole, and rotigotine. These drugs are sometimes used as monotherapy in patients with early disease. Levodopa-carbidopa is very effective, but you don't want to use it right away because after a long time it will lead to the on-off phenomenon. So in patients who have early disease and mild symptoms, these drugs are a good option. Pramipexole and ropinirole are oral drugs, and rotigotine is a transdermal patch. And these drugs have adverse effects similar to levodopa. These are all dopamine-associated effects, things like nausea and vomiting, sleepiness, orthostatic hypotension, and confusion and hallucinations. Tremor-dominant Parkinson's disease is a version of Parkinson's where the patient has a symptomatic tremor, but they do not have significant bradykinesia or gait problems. In other words, the dominant problem is the tremor. These patients have a better overall prognosis than patients with other forms of Parkinson's. And in addition, this is the situation where anticholinergic drugs are often used, because anticholinergic drugs are very effective at suppressing the tremor of Parkinson's disease. Trihexyphenidyl and benztropine are M1 muscarinic acetylcholine receptor antagonists, so they block acetylcholine receptors. This helps the tremor, but it brings with it all the usual side effects of blocking cholinergic receptors, things like sedation and dry mouth. Amantadine is an antiviral drug, but it also has mixed properties as a dopamine agonist and an anticholinergic drug. So this is another drug choice that can be used in tremor-dominant Parkinson's disease. It's also sometimes used in patients who have regular Parkinson's disease but relatively mild symptoms. So here's a summary of all the treatments for Parkinson's disease. These are high yield to know for your boards. The idea here is that these drugs either boost dopamine activity or they decrease acetylcholine activity, as we talked about earlier. These first four classes of drugs all target dopamine, and the last two target acetylcholine as well as dopamine in the case of amantadine. There are some drugs which are usually avoided in patients with Parkinson's disease, so let's talk about those now. Metoclopramide and prochlorperazine are dopamine blocking drugs, so they can potentially make Parkinson's disease worse. These drugs are used to treat nausea and vomiting. They are sometimes used in patients with Parkinson's, but you have to use them with caution. And then most antipsychotics work by blocking dopamine, so therefore they can make the movement effects of Parkinson's worse. I talk about antipsychotics in detail in a video in the psychiatry section, but the antipsychotic drug that has the least movement side effects is the second generation antipsychotic quetiapine. And if you have a patient who has Parkinson's disease who develops psychosis for any reason, this is the drug of choice because it's least likely to have movement side effects. And the way many people remember this is through the mnemonic quetiapine is quiet, meaning it does not have movement side effects. There are some surgical therapies available for Parkinson's. These are often reserved for younger patients who want to avoid the long-term use of drugs over the course of their lives. The two surgeries that used to be done were a pallidotomy, which was a partial ablation of the globus pallidus, and a thalamotomy, which is a partial ablation of the thalamus. These structures are part of the basal ganglia, and they become overactive when dopamine is depleted in the central nervous system. So by partially ablating them, you would limit their activity, and that could improve symptoms. The modern option is to use what's known as deep brain stimulation. This is the implantation of a device that actually stimulates the brain. It stimulates the subthalamic nucleus and the internal globus pallidus, which are also parts of the basal ganglia. And when you provide high-frequency deep brain stimulation to these areas, you actually suppress their neural activity. And just like with surgery in the old days, this leads to improvement of Parkinson's disease. The nice thing about this is that it's reversible. There's no destruction of tissue like there was when brain surgery was done for Parkinson's. Lewy body dementia is a form of dementia that shares some similarities with Parkinson's disease. A Lewy body is a protein collection in neurons. You can see it on pathology. This is an example of one on this slide. And Lewy bodies develop in the central nervous system in both Parkinson's disease and in Lewy body dementia, but they develop in different places. So I told you earlier that patients with Parkinson's disease can develop dementia, but the dementia always occurs late, usually many years after the patient has developed motor symptoms. In Lewy body dementia, the dementia develops before the movement symptoms or at the same time, and that's how the two disorders are distinguished. Otherwise, they can look similar. Both disorders can have movement symptoms, and both disorders can have dementia. And in fact, both diseases are probably a continuum of the same disorder. I'll finish with this slide and mention the term Parkinsonism. This refers to symptoms like tremor, bradykinesia, rigidity, or postural instability. These are the symptoms associated with Parkinson's disease. But Parkinson's disease is not the only disorder in which they occur. They can occur in many other neurodegenerative disorders. Most of these are very rare. I've listed a few of them here. These include multisystem atrophy, progressive supranuclear palsy, and corticobasal degeneration. These are called Parkinson plus syndromes because they have the symptoms of Parkinson's disease, but they have other neurologic symptoms as well. And sort of the defining feature of these other Parkinson plus disorders is that these disorders do not respond well to levodopa, and that distinguishes them from Parkinson's disease. You can also see Parkinsonism in patients who are taking drugs that block dopamine activity. We've already talked about some of these. These are antipsychotic drugs and metoclopramide. These drugs block dopamine activity, and they can lead to symptoms similar to Parkinson's disease, especially in patients who take them chronically for a long period of time. And that concludes our module on Parkinson's disease.